So what are the main parameters on high frequency jet ventilation? So as I said, we won't discuss much about jet ventilation because we don't use it in most of the areas where I would be covering here. So it's not routinely available in most countries. It's used in US and Canada. A jet of gas is forced into the airway with the high velocity, and there is passive exhalation. So the exhalation is not active. You need adequate time to allow for this passive exhalation to happen. The endotracheal tube position is important because if it's baby is turning the neck and the tube is hitting somewhere around the airway, the high velocity jet can cause tracheobronchitis. So the tube position, the head position is very important, and also the leak is important. If there is a high leak, the velocity of the jet will drop and it may not be as effective. As I said, you need a good expiratory time to allow for this. So you can't go to very high frequencies, and your average frequency used is 4 to 8 hertz. Often you use a backup of intermittent mandatory ventilation on top as well to reduce the load on the lungs and to help with gas exchange and oxygenation. So it's like recruiting with sigh breaths at a certain rate. So the I time is usually fixed as 0.02, but it can be a little higher or lower than this if needed. This is a comparison of high frequency oscillatory ventilation, jet ventilation, and interrupter. So the pulses are generated by a piston or venturi or a reverse jet in high frequency oscillation. So the piston was a Sensor Medics and the Dragonfly, while the venturi is used in the new Dragger and similar ventilators. The jet ventilation, there is a pinch valve or injector cannula which generates the velocity of the jet, and flow interrupter, which is not much used. It's like a solenoid valve or a rotating ball, which was the previous type used in SLE ventilators as well as the old type of dragger. The IE ratio in high frequency oscillation is 1:1 to 1:3. So the modern ventilators allow up to the full range, while in Sensor Medics, for example, it was inspiratory time 33%, so it will be 2:1 as a fixed ratio. The high frequency jet, you have 1:4 to 1:9. You need a longer expiratory time, and same with the interrupter, 1:3 to 1:6, because the exhalation is passive in both of these while it is active with the velocity coming back and forth in the oscillation. We can impose a psi in the modern high frequency oscillators, and you can do that with the jet and flow interrupters as well. And this is how the waveform looks. The main difference is the active exhalation. So the inspiratory and expiratory time can be equal. The 1:1 ratio is possible in the oscillation, while it won't be possible in jet or interrupter. So the mean airway pressure is the most important setting for oxygenation, and we will discuss how we choose the mean airway pressure according to the disease condition, especially when it comes to discussing recruitment versus non-recruitment. The frequency is typically set between 8 to 15 hertz. The bigger the baby, the lower the frequency you set. The smaller the baby, the higher the frequency you go to. But obviously it also depends on the disease condition, which we will be reviewing in detail. Amplitude determines the tidal volume. So if it is volume guarantee, the amplitude is adjusted automatically by the ventilator within the range that you provide. So this illustrates why the high frequency ventilation is relatively protective to the lung. So we have the mean airway pressure around which the amplitude oscillates, and the degree to which the pressure is conducted during this oscillation is depending on the frequency. The lower the frequency, the more pressure is directed and the tidal volume is higher, while the higher the frequency, the less this pressure is targeted. So the higher frequency is relatively more lung protective, and as you can see, the range doesn't go into the range of atelectotrauma or volutrauma, which often happens with your conventional ventilation. When the pressure goes to the PEEP, it may go below the closing volume and there may be atelectotrauma, while it in the peak of the inspiration it can cross the distending levels and cause volutrauma. So conventional ventilation, there is a bigger shear stress, while with high frequency this is avoided. And as we discussed in the earlier slides about how the gas exchange happens, the gas exchange happens effectively even without interference with the lung injury part. What are the determinants of gas exchange? So in conventional ventilation, we have the rate, frequency, and the tidal volume or the PIP affecting ventilation, and the peak inspiratory pressure, I time, and FiO2 affecting the oxygenation. While in high frequency, the oxygenation is affected mainly by the MAP and the FiO2, while ventilation is affected by amplitude, frequency, and I time. So these are the rough indicators, but when we come to volume guarantee, the pattern doesn't exactly correlate. The direction of changes, for example, in without volume guarantee, dropping the frequency in high frequency improves the tidal volume, increases the tidal volume, and so the CO2 washout improves. While when you have volume guarantee, the tidal volume automatically gets adjusted. So when you increase the frequency, your carbon dioxide washout improves. So slight differences when you go to the modern forms, and we will discuss that as well. It's very important to understand why going to a very high amplitude is not necessarily the best thing, as well as dropping the rate is not necessarily the best thing. So when we have a higher amplitude, the stroke volume will increase, and this results in a delta P increasing. The frequency decreases, then there is a longer cycle time. So the pressure conduction to the airway increases, and so the lung injury risk is more when you have either a high amplitude or you have a lower frequency when the amplitude is magnified. So this illustrates why having a frequency of 4 Hertz, your amplitude, the larger the volume displacement, and so the effective amplitude, the effective pressure conduction is going to be more, and higher frequency reduces this impact. The DCO2 is a marker of alveolar ventilation in high frequency ventilation. So in conventional ventilation, the carbon dioxide is determined by tidal volume times frequency, while in high frequency, an increase of DCO2 usually decreases the PCO2, and it is equal to frequency times the square of the tidal volume. So in high frequency, the tidal volume has higher impact than the frequency, and obviously if you keep the tidal volume constant, the frequency will make an impact, which is why it happens with the volume guarantee.